live? We're live! Woo! I'm a little punchy today. Okay, so welcome to Healthcare Triage Live. We're so glad that you joined us. We're just making final adjustments. We had some interesting things going on in the office. Our neighbors are moving or something, and they have been talking as loudly as humanly possible in the hallway all morning, which has made it very hard to tape 2 episodes of Healthcare Triage. But we powered through, and we got it done. That's how we do things. As always, a little bit of housekeeping. Check out our Facebook page, facebook.com/healthcaretriage. We appreciate all the support. Check us out on Twitter, at HCTriage. Hey, I hit 20,000 subscribers, I think, just this morning on my own personal Twitter account. So if any of you are among those, I really do thank you. Our Reddit is reddit.com/r/HCTriage, getting more and more popular. I went through last week and answered a whole round of questions on there because I had some time. So you too could get that done if you went to the Reddit site. And finally, 2 things. Check out our merch at, what is it? It's HCTriage.com. That's what it is? HCTriage.com? HCTmerch.com. HCTmerch.com. You should go check it out. I will keep banging the table. Oh, well, you could get the mug. And you could get the poster, although we don't even have the poster up. And finally, to all our patrons, someone became a big patron recently. We have not yet figured it out because I just noticed it minutes ago. We really appreciate all the support from Patreon.com. Patreon.com/healthcaretriage. It allows us to do all kinds of new, bigger, better things, and we've got lots of plans and lots of exciting stuff going on, and we're all super excited by it. So let's begin. Question number 1, Super David 6000. I'm curious to know if any liver detoxification methods or ingredients have any statistically proven research beyond them, and if there's any conclusions we can draw from it. The liver's job is to detoxify the body. That's what the liver does. That's what it's been doing forever, like in every pretty much animal that has a liver. So the idea that we have to come up with more means to detoxify the liver, we're not going to do much better than evolution has done already. Of course, if you're damaging your liver by, say, drinking too much alcohol, the best thing you can do is stop that. Or if you're using other substances that damage your liver, then stop that. But all of the things which are promoted to clean up the liver or make it cleaner or detoxify it sort of ignore the fact that the liver is already awesome at that. That's what the liver does. And so I don't know of any liver detoxification methods or things that you could take that prove that it quote-unquote detoxifies the liver. I'm not sure what that would look like anyway. Like what do people think are the toxins in the liver? The human body is incredibly good at excreting most stuff, and the stuff that it's not good at is stuff you shouldn't be putting in your body to begin with. Do that. That's your best way. Question number 2, Guitar Love 4624. Does sleep position make a difference in quality of sleep? What does the research say? Well, of course, the snarky guy in me says, yes, sleeping on your head doesn't work so well. Sleeping on your back or prone is much better. But if you're asking me about whether you should be on your side or your back or your stomach, for babies, yes. Huge back to sleep program started decades ago because there's a fairly decent amount of epidemiologic evidence that babies have a lower risk of SIDS or sudden infant death syndrome if they sleep on their back. That they have a higher risk of SIDS if they sleep on their stomach. SIDS, for those of you without kids, is the number 1 killer of children outside the neonatal period. It is still to this day not widely understood. It is when babies just die in the middle of the night. Some people think it has to do with asphyxiation. Some people think it has to do with carbon dioxide or with heat. The truth of the matter is we don't know. There are some people that even think it's not real and that a lot of it is like just undiagnosed abuse or something else that's going on. But there seems to be a decent amount of evidence that babies should be put on their back to sleep. That is the best way to prevent SIDS, other than, of course, not smoking around them and doing other stuff as well. But back to sleep for babies. After that, once they can roll over, there's only so much you can do. It is impossible and silly to watch your baby sleep if they roll onto their stomach to try to go flip them on their back, because only a fool wakes a sleeping baby. And I made that mistake more than once because I tried to roll Jacob back onto his back after he rolled on his belly. It's stupid. It's a waste of time. They learn to roll. And at that point, they're sort of outside the risk of SIDS anyway. But you're asking, I'm sure, as an adult. I fall asleep on my back and then I roll onto my stomach. That's usually how I find myself. My wife sleeps completely differently. I think most people sort of naturally fall into the position at which they are the most comfortable for sleeping. I don't know of any evidence that says people should try and change their sleeping habits because they're going to get higher quality sleep. Obviously, people that have things like sleep apnea need to wear like a CPAP mask in order to sleep better. Won't be able to sleep on their stomach as well. They're going to have to sleep on their back. And of course, using the CPAP will make their sleep of higher quality anyway. So all of these are a way of saying I don't know of any good evidence that says you should try to change your sleep patterns to get a better quality sleep. Unless you're sleeping on your head. Like literally upside down on your head. Third question, a JD. I assume you're a lawyer. I exercise lightly for well over an hour each day using an exercise bike while I YouTube. Is this too much? I rarely feel tired or sore, but after should I schedule rest days anyway? Well, it's not too much exercise, but I don't know how much, maybe it's too much YouTube or not enough YouTube. I don't know. But look, if you're exercising an hour a day and you rarely feel tired or sore, that's great. Should you schedule rest days anyway? Well, you don't have to. Again, there are people that like to walk every day. There are people that like to run every day. A lot of the rest that you hear about exercise is more about people who are trying specifically to add muscle mass, and they're talking about, straining and then resting, and the straining and then the resting allows the muscle theoretically, I'm not even sure how good the research is in this, theoretically to grow. That the rest period is when, the straining is like you actually cause damage. The rest is when it actually is allowed to grow. For the purpose of being in shape or doing aerobic exercise, there's no requirement, for resting or rest days or anything else. On the other hand, you're getting more than enough for health benefits. If you want to rest a day, go ahead. I'm giving you permission. Although I'm not giving you medical advice. Because we here at Healthcare Triage do not give medical advice over a YouTube show. If you need medical advice, you should speak to a healthcare provider, a doctor, nurse practitioner, a physician assistant, someone in the medical field. Nothing of what I say today should be construed as me giving you medical advice. Now that I have that out of the way. Anyway, rest if you like, you don't need to. Dynamics Wear Pro asks, I've been reading about Oxycise, an exercise program where you supposedly can lose weight by the way you breathe. Is there any evidence to show that the way you breathe has an effect on your weight? No. Just no. No, if you could lose weight by breathing, wouldn't everybody be doing that? I mean, it would be on the front page of the paper. It would be in every journal. It would be in every news story across the nation if there was supposedly a magic way to lose weight by breathing. I categorically deny that there's any evidence that I know of, well, certainly that I know of, where that could be true. If you know of any, by God, send it to me. I swear to God, that will be the topic of the next Healthcare Triage. Molly Valentine, I was diagnosed with shingles at age 22. I haven't had an outbreak in 2 years. What are some of the ways I can keep it that way? What causes outbreaks? Oh, that's just terrible, Molly. So shingles is when kids have varicella or chickenpox, they do not get cured. What happens is that when the body finally sort of fights off the infection, the virus actually goes dormant deep in your nervous system. It's still there. It's just your body sort of keeps it in check. The problem with shingles is that it breaks out and it affects parts of your body. Ironically enough, if you take anatomy or if you go to medical school someday, you will learn that the way that the spinal cord innervates the body is that as you move down your spinal cord, you're innervating different sections of the body. So by pointing at certain spinal sections of your vertebra, we can say the spinal cord at this level might affect here. The spinal cord, at this level might affect here. And people, when they have shingles outbreaks, have them specifically in what we call the dermatomes, or the areas of the body innervated by that specific nerve. So remember, the virus is living in your nervous system, so it breaks out into individual offshoots, say, of the spinal cord, and so you get the rash in those areas of the body. So it's not like it spreads from here all over. It'll stay in those areas by the way that you're innervated by nerves. So it's just interesting. It's horrible to have, though. You can't sort of spread it from one area of your body to another. It's not that kind of rash. It's unfortunately a terrible, painful thing for many people to have. I wonder, I don't know. I'm going to be honest with you. I don't know about how to do the outbreaks, but you should absolutely talk to your doctor. I wonder about the vaccine. There's a shingles vaccine that we usually give to the elderly. Whether that would work, I wonder if there's any kind of prophylaxis that might be used using one of the antiviral medications. But I don't honestly know. I do know that some people think stress can be related to outbreaks. And so, of course, limiting stress in your life might be a good idea. That's easier said than done. My chronic condition sort of says no stress too, and I don't know how good I do with that. But you should absolutely talk to your doctor. Absolutely. And I wish you the best. Maggie D, is there a nutritional difference between cooked versus uncooked food or the way the body absorbs it, etc.? I suppose there's probably some, but it's not nearly as much as probably people make it out to be. You're going to get the vast... Of course, if you cook your food until you burn it completely and you denature the proteins and you make it unedible or burn it, it's like then of course it's not edible. But if you're worried about the difference between like steamed vegetables versus raw vegetables, you're getting good stuff from both. If you're talking about fruit versus like processed, cooked fruit, I imagine it's the same. And when you eat a steak, you're getting tons of protein, whether it's raw or cooked. So the absolute differences are probably minimal. Are they statistically significant? Maybe, but not clinically significant. And that's really what you should care about. VV, are those dental x-rays safe for kids? They get them more than one time a year when being monitored for mouth expanders and braces. Do they? I don't know. I don't actually know that. Are they safe? Everything is always on a spectrum. It's like, is there a 0% risk from an x-ray? No. Is it usually, you hope that the benefits you might get from it outweighing the risk? Yes. There's a lot of controversy over the periodicity of the x-ray schedule, whether, we should be getting it as much as a lot of dentists try to order them. This is especially confounded by the fact that many dentists make money or own the equipment, and therefore they have a financial incentive to encourage as many x-rays as possible, and so some people feel like they're pushing it harder than they need to. It's also not totally clear that getting all those x-rays all the time is necessary, and if something is unnecessary or not doing good and it has any harm at all, then why are we doing it? Especially if it costs money. So are all the x-rays necessary? Probably not. Are they safe in the sense that is there probably going to be a long-term detriment to most kids? No. But I don't know that kids who get mouth expanders and braces are necessarily supposed to be getting x-rays all the time like that anyway. What are they monitoring? For getting your teeth monitored while you have braces, that's done by sight. The same sort of with mouth expanders. So I'd talk to your orthodontist and ask if those x-rays are absolutely necessary or if that's common practice, because I just don't know. Jason Hogan PEI. Is that Prince Edward Island? Is that what that is? Oh, big Anna Green Gables fan. So that's great. I'm rambling today. Any research papers on whether or not cracking knuckles reduces grip strength with age? All right. Cracking knuckles does not reduce grip strength with age. In fact, the idea that there's some kind of harm from cracking your knuckles is a myth, and it was in our first book. You should buy it. When you crack your knuckles, what's actually happening is you are pulling on the joints in such a way that you're creating a vacuum, which lowers the boiling point for the joint synovial fluid, and that's sort of it's actually boiling. That's what you hear. Now, when I say boiling, that doesn't mean super hot. It's just that the gas, sort of escapes the synovial fluid at a very low temperature, a reasonable temperature when you actually pull on your knuckles and crack them. But that doesn't actually cause damage. It's not linked to arthritis. It's not linked to any other physical problems. It can make you very unpopular. So I suppose it could be bad for your social health, but not for your physical health in any way. Certainly not for arthritis. Certainly not for your grip strength, which remember is going to be more muscular anyway, not really about the bone. So there you go. Sarah Melnick, my doctor told me that skipping the placebo week on the pill and starting the new pack is bad because the body needs a chance to clean itself out. Is this true? I'd heard in the past that it was safe. Okay. First of all, for the perspective of getting, the hormones that you need to get the contraceptive effect of the pill, skipping the placebo week does nothing. The reason that there's a placebo week is usually at least twofold. One, it's because, as you likely know, it's important to take the pill every day at about the same time. It's very habit forming. And if you stop for a week, it increases the chance that you might lose the habit and therefore not remember to start the pill up again, or that you might get out of habit and not remember to take it at the same time every day. The second thing is they often, I don't know if they do so much anymore, they used to put sort of iron supplements in the week off, with the idea of that would give you iron supplementation while you were menstruating. It would prevent any possible anemia, especially if your diet is not very high in iron. So yeah, I suppose it could lead to a statistically significantly higher chance of anemia, even though that's probably not terribly clinically significant. And there's plenty of other ways to get iron. You don't have to get it from the placebo. It is therefore safe, which is what you're asking, to skip the placebo week. It just might still be a good idea to do it anyway, to keep yourself in the habit and give you whatever vitamins, minerals, or iron supplements that they're putting into the placebo for you. So there you go. Monica Lau asks, although women of childbearing age who are expecting or attempting to become pregnant are often recommended to take prenatal vitamins, what does the evidence really say? The evidence says that the folate that you're getting is a big deal, and that's the real reason that we do it. Being low in folate, which is a B vitamin, is absolutely shown to be related to neural tube defects, which would be a real big problem in your developing fetus and baby. You don't want neural tube defects, and supplementation with folate has been shown to be significantly associated with significant reductions in neural tube defects. So getting on that is the real reason. All the other stuff you're getting, there might be some benefit, but as long as you're eating a healthy diet, and most pregnant women I know eat plenty, they probably are getting what they need. But that's why and of course you want that benefit early on for early fetal development. So that's why we tell people, even if they're expecting or attempting to become pregnant, take the folate, take the prenatal vitamin, because you might not know you're pregnant for a couple weeks to months, and you want to be sure that you're not folate deficient while the baby's developing all those things that might be important to avoid neural tube defects. So this is a vitamin I endorse, that I say, yes, I recommend it. My wife absolutely took it. I know that my OB-GYN friends would absolutely recommend that this be true, and the evidence would, I think, agree with it. Matthew Peterson, what's your opinion on sharing clinical notes with patients? I know the studies say it improves patient satisfaction, but do you think it will actually improve patient outcomes? That's a great question with the outcomes, because I wasn't expecting that. So what's my feeling on sharing notes with patients? I don't think that patients... I know this will make me unpopular with doctors. I don't really care if patients see the notes. I think they have every right to do so. Certainly if they subpoena it, they could. The problem, I think the thing that most doctors panic about is that things that they write might be misinterpreted by patients, or they might be taken out of context. And I am sure that is true. I am sure that I have written notes in my career where I was tired, where I was sleep deprived, where I was angry, where I was miserable, where something else was going on, where I was clinically depressed, which absolutely, was likely to happen at some point or another, where I wrote something that was like shorthand or said something that perhaps wasn't the kindest, and it would make me sad to know that a patient would go back and see that, because, sometimes it's your private thoughts and you're putting them down on paper because that's what you're supposed to do, and sometimes things blur. Having said that, we could probably, they should be able to, it shouldn't be like it's privileged or secret. They should know what their labs are. They should be able to know what doctors think about them, what their assessments are, what their plans are. And so that's fine. And if you really feel like a patient shouldn't see something, maybe you shouldn't write it. There are some technical reasons why you would not. For instance, there's privacy issues. Like, other people shouldn't be able to see the note. If I see an adolescent and they tell me something in confidence, I don't want their parent demanding to see it. Because there is some level of patient, doctor confidentiality. And the same goes for, adults as well. Spouses shouldn't be able to demand to see everything. Even other adults shouldn't be able to see everything. So there should be confidentiality. But patients seeing their own notes is interesting. We actually did a study not too long ago that was funded, I think, through the Office of Technology Assessment, where we actually looked at giving patients granular control over their electronic medical records. Like, they want to be able to control what other doctors could even see, who would be able to see the record, whether it would be allowed. So not only letting them see it, but giving them control over who should see it, because why should I as a doctor just be able to go willy-nilly through anything I want and see anything I want about my patient? So, there is a push to go even in the other direction about this. It definitely, I think studies, you're right, improve patient satisfaction. I don't know if they're ones for outcomes, but I do know that there are studies that show that better documentation improves outcomes. And so if patients being able to look at the record forced or push doctors towards better documentation, that is possible a way that you might get to better outcomes. But I don't know if those studies have been done yet. Pink Doobie, just checking the time, says, you've said that improving lab results isn't the same as improving health. What about the opposite? If my lipids and weight are perfect, can a bad diet give me heart disease? Well, okay, so I said, I agree, improving lab results doesn't necessarily mean improving health, but it's like, but I didn't say that bad lab results aren't necessary or that great lab results. What I said was that there's a huge range of normal, and following fluctuations in that range tells you nothing about the long term. And so getting tons and tons of lab results so that you can see trends or things, that's where there's no evidence. There's still no question that when someone is sick and they have an abnormal lab result, we know that that's pretty bad. So if your lipids and weight are perfect, can a bad diet give you heart disease? Well, theoretically, but that's why we monitor the lipid. There's a reason to order yearly lipids and yearly cholesterol. It's because studies show us that that value ordered yearly, can help us predict who might be at higher risk for problems. But it's not an absolute. For instance, I just got my cholesterol. I eat incredibly healthy these days. And if you're hearing anger from me because I'm irked about this. I just had my labs checked, and I'm eating as healthy as I've almost ever eaten in my entire life. Lots of vegetables, trying to keep down the carbs and trying to keep down the saturated fat, all that stuff. And my cholesterol was in an all-time high this year in a range that, some people might treat. However, when my doctor ran all the calculations, it said that my 10-year risk for having, a heart attack based upon the cholesterol value and everything else in my life was 0.9%, and the average person is 0.8%. So what do you do with that? Diet's not everything. Your cholesterol value, your lipid value, that's what we know from the yearly one. You would know nothing from getting a quarterly one or a monthly one or a daily one. That's what we know for the yearly one. So I'm saying don't get tons and tons and tons of other lab values what we won't know what to do with. Get the ones that we know about. It's also important to know that for things like cholesterol, there's a lot of great research. I think we even have an episode on this, that dietary cholesterol has very little impact on your overall serum cholesterol. That eating cholesterol doesn't necessarily give you a high cholesterol. And not eating cholesterol, which I'm doing, isn't lowering my cholesterol. Probably at some point, if it keeps going up like this, I will need to take a statin or another type of drug to help lower my cholesterol. Not yet, but maybe someday in the future. So I know people that eat terrible diets that have great lab values and very low risk. I know people that eat great diets and have very bad values and are very high risk. So all of those things are possible. None of them say that you should get lots and lots of lab values. M. Avery, do you have to be a doctor to lead medical research? Is there a shift toward nurse practitioners leading research? Was an RA and loved it, but med school isn't for me. First of all, forget even MDs. I work with tons of PhDs. You don't have to have an MD to do medical research. I know, PhDs who knock it out of the park every day and who are spectacular. I know people that have an MD and a PhD. I know nurses who still have PhDs who do amazing, research involving nursing and who still are, doing huge work, NIH, big grants, everything else. I will say that to lead research, you have to have a terminal doctorate degree most of the time. But like I said, that could be a PhD in nursing, that could be a PhD in name your science, that could also be an MD. Most schools will not give you a tenure track position without some sort of terminal doctorate. Could even be, I guess, a JD. We have a member of our section who's a JD. So it just has to be sort of that end terminal degree. And so, nurses and nurse practitioners, my wife's a nurse practitioner. She's been involved in research, but she probably couldn't write a big NIH grant, not because she's not smart enough or, talented enough. But I don't know that, most granting agencies and most jobs, really sort of want to see that terminal degree to lead it. You can do it, you can work in it. My wife's involved in lots of research, and she does lots of projects that she wants to do. But if you want to lead research, you have to sort of most of the time have that terminal degree, but it does not have to be in medicine. Adam Delusky, are there any studies on the long-term 30 plus years or more side effects of statins? No. We just haven't had them in wide use long enough to do that. At some point, we hope that the answer to that will be yes, but we just don't. I mean, it's the same reason we don't have 30 plus years on lots of drugs that have been invented, and we don't have 30 plus years on Viagra because it hasn't been around for 30 years. We just need more time. N Kicker, what areas of medical research do you believe don't get enough funding or attention? This is ironic because I just taped an episode where I sort of harped on this. I wrote a recent New York Times piece on that we adapted into an episode on autism guidelines and research, where I think I make a reasonably strong case that it's ridiculous to ask for this research to make recommendations when we're not funding the research. I think we often give kids in general short shrift when we look at research dollars. We care about them a great deal in society, but we spend the vast majority of our money on end-of-life, elderly research stuff. Even though the kid stuff winds up costing us longer in the long term. Of course, I'm a pediatrician, so people argue that I'm conflicted. How can I be honest? Of course I want more research for kids. That's what I do, but that's why I do it. So yes, there you go. That's an area I think could be better funded. I'm going to try to do some more questions here, lightning round, just to get through the last few. James Pizzini, at what point during a diet cut does losing weight become detrimental to health? When you're underweight? I mean, BMI is not a great way to look at health, but certainly if your BMI starts becoming low, or if you're not feeling good, or you're having negative consequences, stop. Talk to your doctor. That's the best way the answer I can give you. Talk to your doctor. Cameron Alexander, our Patreon research associate. I say your name every week. I'm so excited you're here. Thank you so much for being such a supporter. Do you believe we should invest in increasing the SOP of non-physician providers as a way to deal with physician shortage? Yes. Yes, I do. Again, my wife's a nurse practitioner, so you can say I'm conflicted. But, we absolutely have too few doctors per population in the United States. And what we really have is sort of an average number of specialists. We have a massive shortage of primary care physicians to care for the size of the population in the United States. We could either massively train up physicians, which we're not doing in medical school, we're not doing in graduate school, and we're not willing to pay for, or we can recognize that we have lots of well-trained people who could fill the gaps and do a phenomenal job in helping this primary care shortage. Those include mid-level practitioners, such as PAs, such as nurse practitioners. We absolutely should be allowing that to happen. It is in places all across the country. It's a necessary thing. These people are staffing a lot of the minute clinics and a lot of the acute care clinics that are popping up everywhere to sort of handle what people need in terms of acute care. So absolutely, it's a viable way to deal with the physician shortage. And Cameron Alexander, thank you for being here. Sophia Klimov, hi. I read some symptoms resembling menopause. What are some alternatives if I have hormonal problems and can't get an IUD? Thanks. I have not heard that. Tube tying, it's not that they physically tie a tube. They're just closing off the fallopian tubes. The fallopian tubes are not where the hormones come from. Those come from the ovaries. I'm not aware of research that says that tube tying causes symptoms resembling menopause. Of course, that is an extreme way to do birth control. There are other long-acting reversible contraceptives, or LARCs, which we talked about. An IUD is one. If you can't have an IUD, and I'd encourage you to talk to your physician to find out if that's really true, but if you can't have an IUD, there are also implantable, forms of contraception that last long term and are incredibly good. There are other forms as well. You also should talk to your healthcare provider. There are many options for LARCs, even if you didn't want to do those things. And that will do it. Thank you so much for tuning in. As always, we appreciate it. Check out our Facebook page, facebook.com/healthcaretriage. Check out the Reddit, reddit.com/r/HCTriage. Check out our merch at hctmerch.com. Check out, what else?
It's on the screen.
Was that? It's on the screen. You can just see it there. And of course, patreon.com/healthcaretriage. We really do appreciate all of our patrons. Especially, hey, Cameron Alexander. Cameron Alexander is one of our research associates. Thank you so much for everyone's support. We hope you tune in next week for Healthcare Triage Live. We will also be having news this Friday and our regular episode on Monday. And we appreciate you watching all of those. Thanks again.